Thank you so much. Can you all hear me all right? Thank you so
Absolutely.
much. I see all familiar faces, a lot of friendly faces. So before we start, I just want to know how much time do I have for the slide. So I don't want to go beyond my time limit. So Melina, you have some idea?
I think it is theoretically 10 minutes.
Theoretically 10 minutes. So I'll quickly go through some of my slides here. Maybe I can share my slides. So I'm ARUN Singh from the Kola Institute, Cleveland Clinic. It's a distinct privilege to participate in this seminar. And this topic is a huge topic, but I'm going to limit myself to technique and indications, and mostly diagnostic indications. So we all know about prognosis, and I'm sure we'll talk about it further, but I'll limit myself just to the main crux of it for which it was initially designed, which was for the diagnostic purposes. It goes back to 1979, and in summary, present-day techniques are generally safe and overall reliable, and depends upon which instrument, depends upon which area of the eye we're looking into. If you're looking at iris tumors, ciliary body tumors, or anterior choroidal tumors, you can do an anterior transscleral flap, for example. And I have little videos to show here. I'm not sure if they'll work on the Zoom or not, but let's see, give it a try. So the first step in this, are you able to see that? Let's see here. Huh. Somehow they're not working. The videos are not working. Anyway, the first step, as you probably know, is a triangular flap or a square flap or the partial thickness sclera, and then you pass the needle in, you aspirate it, and once you have aspirated, you submit it into a material, and we'll come back to that. If the tumor is posterior, you can do a posterior equatorial kind of a biopsy, which could be a transvitreal biopsy. And for that, you go 4 millimeter behind the limbus, you put a trocar, and you use the needle. We typically use 25 gauge needle, and you can use 27, and some people will use 30, and some people will do vitrectomy. Whatever you're familiar with, it's okay. But main important thing is to then flush the material into the cytolite. Cytolite is a liquid medium. I'm not able to work my video here. I'm not so sure what may be the cause here. Do you know? Anybody? No?
I'm not quite sure.
Okay. I will skip that part. That's okay. And once you rinse this into the liquid, you should be able to see that there's something is floating about, and then you know it's okay. So I typically use indirect, but you could certainly use vitrectomy-based system. And there is some controversy about indications, but I would say that in general, if you're not sure about the diagnosis, if it's atypical, there's something in the history, and you can't see the tumor very well, those may be the relative indications. Some people will biopsy more often than others, but in broad categories, you can define them into 4 groups. You say, I want to confirm a case of uveal melanoma. It's a tumor near the papillary area, and you say, I want to enucleate this eye. I would say it's very reasonable in current day and age to do a diagnostic biopsy to confirm it's melanoma before you proceed with that. Or you can say, I want to confirm a patient with uveal metastasis, a patient with stage 1 breast cancer, supposedly doing very well, never had any metastasis anywhere, shows up with what you think is a yellowish lesion, suggestive of metastasis. Now that she has no other known metastasis, this is the first time she's going to be diagnosed with metastasis, it's reasonable for you to do a uveal biopsy for the uveal metastasis. And sometimes, even if you think you're very smart, you cannot tell whether it's melanoma or metastasis. Say a patient with a breast cancer happens to have a melanoma, and then you don't know, if, obviously, that it is a met or melanoma. And of course, once in a while, there's a rare tumor where you cannot tell them apart. So let's look at some example. Here's a juxtapapillary tumor. This eye is going to be enucleated. We say, well, I'm going to confirm it's melanoma or not. So that's the thing. So first depends upon the clinical differential. Here there's no differential, but it's very clear, but the treatment is going to be so severe that maybe it's worthwhile doing a biopsy. You really want to speak to the cytopathologist, tell them what you think is the differential so they know the context of the interpretation. We know in FNAB, uveal melanoma, 98% will have spindle cells. So first thing you really want to see is the spindle cell. You do not have spindle cell tumors metastasizing to the choroid. Almost all melanomas have spindle cells. So if you can see spindle cells, you would say it's very likely a uveal melanoma. And the second thing you look for is melanin. Again, we don't have cutaneous melanoma or other pigmented tumor, commonly metastasizing to the uvea. So if you see pigmented cells in the tumor sample, you say it's a melanoma. Of course, we know that it can also be an amylotic melanoma. And the last thing are the immunohistochemistry. So you can do immunohistochemistry on this for melanoma markers or others based upon what you have in interest. I'm going to give you quick examples, then we'll stop. So here's a patient who has a non-responsive scleritis going on for months and months, and you can see something yellowish in the angle. You do UBM, you see a ciliary body mass. You do a biopsy, you say this is adenocarcinoma coming from the lung, for example. So this masquerade as uveitis or scleritis. Here's a patient who has two primary tumors. He has multiple myeloma and neuroendocrine tumor. He has a pigmented mass. You say, well, does he have two primaries and one met, or does he have three primaries, which is, say, a melanoma? So here you don't know what's what. You do a biopsy and you say, oh, this was actually a neuroendocrine tumor. Now, we know there's no good chemotherapy for neuroendocrine tumor. You can plaque this patient, and it did very well. So that's the final thing. And the last one, here's a patient with an RPE tumor. Now this, most of us clinically can say, well, this is not melanoma, but this was starting to grow. We had a documented growth on this tumor. We did a biopsy, shows it to have flat epithelial cells, very different from the spindle cells of melanoma. So these are the four main categories, I would say, in your mind, and you tell the cytologist, oh, it's a melanoma, I'm going to confirm it. Or, I'm not sure it's melanoma or something else, I need your help. Or, I think it's a met, but it's slightly pigmented, I cannot be sure. Patient has a breast cancer, maybe it's a melanoma, help me. So tell them whatever you have, but you can frame it in these four categories. I think my time is up, 10 minutes, and I'll stop right here. I mean, we have many more slides. Takes you to prognostication, and I'm going to stop there just with the diagnostic techniques, which actually is the fundamental application of FNAB overall in uveal melanoma. Thank you for the privilege.
Thank you, Dr. Singh. I think you still have 2 minutes.
I still have 2 minutes. So the other common indications that you're going to talk about are going to be the prognostication. You say, well, different techniques, and nowadays we are left with just two, MLPA and GEP. GEP seems to be more commonly done in the US, MLPA perhaps outside the US in European countries. What's the most important complication? We say hemorrhage, significant, visually significant hemorrhage, uncommon, usually 1% of cases. Retinal detachment, also uncommon. And why is that so? Because the tumor itself acts like a indentation and helps with the sealing of the retinal tear. And RPE proliferates and seals it. Again, 1% of cases. Tumor seeding is very rare in melanoma because nowadays most of us are using trocars. We did a study doing a cytology of the trocar, and within the trocar you can find melanoma cells about 1/4 of time. So trocar is isolating the needle tract. It's preventing the needle contamination of the wound. Of course, we know in retinoblastoma it's a different story. You do not want to really biopsy retinoblastoma. So that's a very important distinction. FNAB causes very little tumor seeding in melanoma, but the story is very different on retinoblastoma. And the biggest limitation is the negative interpretation. You say, I did the biopsy, I got no results. Only you got is a hemorrhage. That's awful, really. Eyes full of blood and you have no sample to talk about. And that's negative biopsy, we say approximately 5% of the time. And why is that? Why is the problem? So these are because you don't have enough cells. And if you don't have enough cells, you cannot tell it's melanoma or whatever. So you can not say, if you don't have enough cells, that you excluded malignancy. And then you have to go forward. You say either you do an incisional biopsy or some other form of biopsy, or treat empirically if that's an alternative. And how can you avoid a negative biopsy? Well, thin tumors, you're going to have a problem. If you're going to use a finer needle, you're going to have lesser samples. And you really do not want to use dry smears. You must use the cytolite. You must wash the needle and the tube into the cytolite and send it for pathology analysis. So these are the ways you can avoid a negative biopsy, which is highly disappointing, also depressing, and patient anxiety is going higher. So you really can do certain things to avoid. If it's a very thin tumor, many times for prognostication, I'll tell them, I don't think I'll get enough cells, or I can't prove it because it's too small. Okay, I think my time is up now. I'll stop here. Thank you so much again.
Excellent. Dr. Singh, we were wondering by any chance if you could try just one more time to play those videos and see if by any magic they're working.
So I had, let me go back here. I don't know what happened. I mean, I tested them before. I think when it comes here, somewhere in Zoom, somebody has to allow it. I don't know.
Okay. Okay. Thank you. Great presentation as always.
Test them did work on my desktop, but not on Zoom. But that's okay. I'm sure there'll be some other forum, some other time to talk about it. Thank you.
Excellent. Excellent talk.
Thanks, Dr. Singh. It's my pleasure now to present Dr. ELAINE BINKLEY. She's an assistant professor of vitreoretinal surgery and ocular oncology at the University of Iowa. She completed her residency in ophthalmology at the Ohio State University Hanver Eye Institute, followed by fellowships in vitreoretinal surgery and retina, clinical and molecular research. We focus on ocular oncology at University of Iowa. Dr. Binkley is going to talk to us about vitreoretinal approaches to tumor biopsy. Dr. Binkley?
Thank you very much for having me. Is everybody able to see my slides okay? Okay. And I have some overlap with Dr. Singh here, but to kind of start off similarly, indications are diagnostic in cases of uncertain diagnosis, but also prognostication, which can include GEP, multiplex ligation-dependent probe amplification, which is another way of doing chromosomal analysis, single nucleotide polymorphism array, and FISH. And the two commercially available ones, like Dr. Singh said, are GEP and MLPA, but obviously that's limited country to country. But like Dr. Singh said, there's different reasons that a transscleral approach or a vitreoretinal or transvitreal approach might be better depending on the scenario. Some of the pros of a vitreoretinal approach are being able to control the intraocular pressure with an infusion or with injection of BSS into the vitreous cavity. It's generally easier for more posteriorly located tumors, can be more controlled in the setting of smaller tumors, allow for direct visualization of the tumor during the biopsy as opposed to transscleral approach, and the ability to apply laser and control the biopsy site, along with, in some cases, an improved ability to obtain tissue and remove multiple samples. Some of the downsides are that it's more invasive. It can be much harder for more anteriorly located tumors, can be more costly, and possibly a higher risk for vitreous hemorrhage, although that varies depending upon techniques and the literature. But when using a transscleral approach, you can place trocars and inject balanced salt solution to raise the intraocular pressure to decrease your risk for vitreous hemorrhage. You can use visualization either with indirect ophthalmoscopy or with an operating microscope with an inverted viewing system. And many people will use about a 1.5-inch 25 or 27 gauge needle connected to a 10 ml syringe with intervening tubing, like Dr. Singh had showed on his slide, and directed into the apex of the tumor. And then the plunger is withdrawn. And this is not my video, but this was a really nice video from Finn et al., where they've placed a chandelier viewing system. And then they're placing using a trocar to place a cannula here. And then they use an operating microscope using a needle going into the tumor. And then the assistant at this point is withdrawing, so they get their sample. It's important to direct the assistant to not continue to aspirate and continue to pull back on the plunger as you withdraw so that you don't incarcerate vitreous. And then you can see there's just a little bit of hemorrhage at the biopsy site. And when using an inverted viewing system and doing either a complete or partial vitrectomy, you can do a standard 3-port vitrectomy, or in some situations, if the tumor is in a really difficult location to do that, a chandelier can be really helpful, and you can use 2 posts with a chandelier. there's debates about whether or not to perform a limited or a complete vitrectomy, and there's different times that it may be advantageous to do that, especially in young patients when the hyaloid's down, to have easier access to the tumor. Some will at least lift the hyaloid off of the tumor to be able to have easier access. And then one of the nice things about using an infusion is to be able to control the intraocular pressure really carefully to help tamponade any bleeding. A lot of times I like to use endocautery at the biopsy site to pierce into the retina. A microvitrectomy blade can also be used. And then 25 or 27 gauge cutter, I mean, smaller gauge cutters are being used as well. I think the nice thing about 25 and 27 is also using smaller needles also has, smaller sample size. And obviously we want to get a diagnosis. But again, the cutter can be connected to a 10 cc syringe. Generally want to turn the cut rate down to more like 300 to 500 cuts per minute within the tumor. And then it's really important to very gradually lower the infusion pressure. I usually take it down about 10 millimeters of mercury at a time, and I'm always watching carefully for any hemorrhage, and then we'll raise the pressure back up if it looks like there's any significant bleeding. And then to decrease the risk for any extraocular tumor extension, sclerotomies are sutured, and then many would also apply cryotherapy to the sclerotomy sites as well. And this is just one limitation of a vitreoretinal approach as opposed to a transscleral approach, is that since you aren't placing a plaque directly on the biopsy site, since it's across from the eye, there is theoretically a higher risk for extraocular tumor seeding, although that it hasn't really been occurred much in the literature. And so the overall thought is that risk is very low. But some general tips for a transvitreal technique is to again consider using a chandelier depending on the tumor position if the lighting is going to be inadequate with the traditional approach given the location. Again, ensure that the assistant isn't aspirating on the syringe as the cutter or the needle is withdrawn so that vitreous isn't pulled up with the sample. Consider a limited pars plana vitrectomy to access the biopsy site, and then separation of the hyaloid from the biopsy site to decrease the risk for having retinal breaks with your biopsy. And again, very slowly lowering the intraocular pressure afterwards, avoiding retinal vessels, trying to sample the thickest part of the tumor and avoiding the fovea. And then, like we alluded to, most tumors are elevated enough that it creates a buccal effect that endolaser at the site probably isn't necessary, but in some thinner tumors especially, it's just something to consider. And Dr. Singh already pointed out his paper, but I just wanted to make the point that there have been debates about whether to use valved or non-valve cannulas, and his paper showed that there were tumor cells that were able to be collected from the valve leaflet, suggesting that a valve system may be better in terms of decreasing the risk for extraocular tumor spread. And like Dr. Singh said as well, communication with pathology is really important in cases, especially for diagnostic biopsy, and letting the pathologist know ahead of time what you're looking for is really important. Different institutions and pathologists will use different media. RPMI, Sakamono's fixative could be used depending on the clinical scenario. And then most of the commercial testing either come with their own kits or their own instructions for the media of choice. And so it's important to know that ahead of time and know how the sample needs to be transported. And this was an example of one of my patients that we published, that we had used a vitreous cutter assisted approach to diagnose a patient that it was unclear diagnosis that had features of both a melanoma, but also it had a history of squamous cell carcinoma of the tonsil, and ended up being metastatic squamous cell carcinoma of the tonsil. But I think one of the nice things about the cutter assisted approach in some of these scenarios is you can get a little bit bigger volume of tissue if you're careful with how you get your specimen. And I just think it's a nice thing to just kind of be able to do in some of the diagnostic cases. It's not perfect in every case, but it certainly has a role. So I think both transvitreal and transscleral have approaches and are important in both diagnostic and prognostic biopsies of choroidal lesions. With transvitreal approach, kind of the main risks are vitreous hemorrhage, extraocular tumor extension, and retinal breaks. And again, all of these techniques can help to decrease the risk of those things. Controlling the intraocular pressure to minimize bleeding is really important. And both indirect ophthalmoscopy and vitrectomy assisted systems can be used. And then close communication with ocular pathology is really important. So thank you.
Hi, Dr. Binkley, fantastic presentation as always. I will invite our next speaker and give an introduction to Dr. KATHERINA ALSINA, PhD. She's the Associate Director of Scientific and Medical Affairs for Castle Biosciences Uveal Melanoma Division. She joined Castle Biosciences in 2019 after serving as the Senior Project Manager of Cardiovascular Research Institute at Baylor College of Medicine in Houston, Texas. In her current role, she supports all aspects of the company's uveal melanoma molecular testing portfolio. She's the author of many publications and has presented her work locally, nationally, and internationally as well. KATHERINA ALSINA, please take it away. Thank you.
Thank you so much. Can everyone see my slides?
Absolutely.
Perfect. It is really an honor to speak to you today. I'm with Castle Biosciences, so I'm going to give an overview of the molecular testing services that we offer for uveal melanoma patients. But first, let's advance the slides. First, I wanted to give just a kind of a bird's eye view of Castle for those of you who might not be as familiar with our company. We're a US-based diagnostics company that we're really focused on trying to transform disease management and improving health through innovative testing that can guide patient care. So this is a snapshot of our current portfolio of tests. And as you can see, we provide testing across a wide range of disease states, including uveal melanoma. And so our uveal melanoma test, DecisionDx-UM, which is the gene expression profiling test that Dr. Singh and Dr. Binkley were referencing, this was the first test that our company successfully launched back in 2009. And since then, we've gone on to develop other tests that are shown here. But the DecisionDx-UM test is now used in about 90% of 80 to 90% of newly diagnosed patients around the US to determine metastatic risk in newly diagnosed uveal melanoma. So I'm going to jump right into the different tests that we offer. In addition to our gene expression profiling test, DecisionDx-UM, we actually offer 2 additional adjunctive tests that I'll talk about as well. All 3 of them can be run from a single biopsy of the primary tumor. And the tissue that's shown here, it can either be from a fine needle aspirate biopsy or from formalin-fixed paraffin-embedded tissue, say from an enucleation. But we can run 3 different tests from the single biopsy. So the top 2, DecisionDx-PRAME and DecisionDx-UM, are both RNA-based tests that use standard RT-PCR to look at gene expression levels. So they're gene expression profiling tests. And the bottom test, DecisionDx-UM-Seq, is a DNA-based test that can identify mutations in the 7 genes that are commonly mutated in uveal melanoma tumors. So taken all together, these tests really offer a very comprehensive molecular profile of the tumor. And again, all 3 can be performed from a single initial biopsy. Now, these are what the results of each of these tests look like. And it's a lot of information, but I'll go through each one of these one by one, focusing on DecisionDx-UM, which is the test that gives this class 1A, class 1B, or class 2 result. This test is the only one of the 3 that we offer that has been prospectively validated and confirmed across multiple studies. The other 2 tests, which I'll talk about at the end, are, again, optional adjunctive tests, but their prognostic value is still under investigation. So the DecisionDx-UM test looks at expression levels of 15 different genes in the tumor to determine whether the patient is at low risk, intermediate risk, or high risk for experiencing metastasis within 5 years. And it's very important to note that the test has to be performed before the tumor tissue has been exposed to radiation, because we don't know how radiation can affect the gene expression levels. I'd also like to point out that this test has been included in US national guidelines, the National Comprehensive Cancer Network guidelines for uveal melanoma, since they were first developed for uveal melanoma patients in 2018. And so the guidelines are shown here on the right-hand side. They recommend different imaging intervals for patients based on their test result, their class result, with the high risk class 2 patients being recommended more frequent imaging, as well as recommended that they discuss entry into adjuvant clinical trials. Now, in terms of the evidence supporting use of this test, there's a lot of published studies that have looked at the DecisionDx-UM class results. So the first clinical validation of the test came out of a study by the Collaborative Ocular Oncology Group, or the COOG. And this study included 459 patients from 12 centers who all of these patients were prospectively tested with DecisionDx-UM. And you can see about 60% of the tumors from the pie chart, 60% of the tumors came back as low risk, so Castle class 1, and 40% came back as high risk, Castle class 2. And what's striking on the right-hand side, if you look at the survival curve, it was very clear that the test was highly accurate at predicting metastatic risk between those two groups. So at 5 years of follow-up, 97% of the class 1 patients remained metastasis-free compared to only 20% of the class 2 patients. And in multivariable analysis, comparing the class result to other features like clinical factors, pathology, and chromosome status, the DecisionDx-UM class result was superior in terms of predicting outcomes. So since that initial COOG study that I just summarized, many independent studies have been published, and those are summarized here, that support use of this gene expression profiling test, the DecisionDx-UM test. And altogether, these published studies have included more than 3,300 uveal melanoma patients. So really a very robust body of evidence supporting the test. This schematic just summarizes how clinicians are incorporating the test into their practice to guide decisions about metastatic surveillance in clinical trials. And the main take-home message here is that with the DecisionDx-UM test, the high-intensity surveillance and adjuvant treatment can be focused on the high-risk patients, the class 2 patients who really need this type of management the most to promote early detection and treatment of metastatic disease. And conversely, the class 1 patients, the low-risk patients, who really account for the majority of tested patients, 60% of tested patients, can be removed from such aggressive surveillance since they're highly unlikely to experience metastasis. Now, I wanted to highlight a recent study that looked at patient perspectives around prognostic testing in uveal melanoma, because we know patients play a very important role in the planning of their care. And so this was a recent study published in collaboration with the Melanoma Research Foundation and Dr. Williams, who really led the charge here in designing the study. But it explored patient attitudes towards prognostic testing. And 177 uveal melanoma patients participated in the survey. 90% of them reported wanting prognostic information at the time of their diagnosis. And of those who had testing specifically with DecisionDx-UM test, 99% reported gaining value from their test result. And this was regardless of whether they were a high risk or low risk patient. So in particular, the high-risk patients reported benefiting from a better understanding of their tumor biology and more personalized care. And the low-risk patients reported feeling a sense of relief from uncertainty about the future. Another important finding from this study was surrounding decision regret after testing. So patients really experienced low decision regret levels regarding this decision to undergo prognostic testing, regardless of whether they had a high or low risk test result. So just a couple of slides now about our additional tests, DecisionDx-PRAME and then DecisionDx-UM-Seq. The PRAME test determines whether a tumor is positive or negative for expression of the PRAME gene. So just like the DecisionDx-UM test, it is a gene expression profiling test that looks at mRNA levels, but just of one gene. DecisionDx-UM is looking at a combination of 15 genes that are increased or decreased in the tumor. This one just looks at PRAME. So the reason that we started offering PRAME is that several years ago, there was some interesting work published by Dr. Bill Harber's group reporting that increased expression of this PRAME gene is associated with a higher risk for metastasis, regardless of whether the patients were class 1 or class 2. And so this summarizes that 2016 study where they found that all of the class 1 patients who were PRAME negative, this is the Kaplan-Meier curve on the left-hand side, all of the patients who were class 1 PRAME negative, so the blue line, remained metastasis-free after 5 and 10 years of follow-up, whereas only about 60% of the class 1 PRAME positive patients were metastasis-free at 5 years, and all of them had experienced metastasis at 10 years. So it seems increased levels of PRAME is associated with a higher chance of metastasis within that class 1 group. And in the class 2 patients, which is the graph on the right-hand side, it seems that PRAME positivity seems to be associated with a shorter time to metastasis. So PRAME may somehow promote faster metastasis in the class 2 patients. However, the exact clinical implications of PRAME are still under investigation. PRAME has not been prospectively validated yet as a biomarker, but it is currently being evaluated in an ongoing multi-center study called the COOG-2 study. But because of the excitement around PRAME, Castle started offering PRAME testing back in 2016. And finally, our SINGH test. This is our DNA sequencing panel that can detect mutations in 7 genes. Now, the 3 genes shown here on the left are associated with differential metastatic risk. And the 4 genes on the right don't seem to be prognostic, so they're not associated with different metastatic risk, but they may help to confirm that a melanocytic tumor was actually sampled. And I'll talk a little bit more about that here. So we started offering the sequencing test in 2018 due to a rising interest in mutational profiling of uveal melanomas. And so this diagram shows in yellow the genes that are commonly, or they're early driver mutations commonly mutated in uveal melanoma tumors. The vast majority of uveal melanomas will contain mutations in one of these 4 genes in yellow. And so these mutations almost always occur in a mutually exclusive pattern. And again, they're considered early, driver mutations because they occur early on in tumor development. Now, mutations in the 3 genes on the right, EIF1AX, SF3B1, and BAP1, occur later in tumor progression, and they are thought to be associated with different metastatic risk. And so to give a little bit more detail about those 3 mutations in particular, mutations in EIF1AX in green occur in about 20% of all tumors, and they seem to be associated with a lower risk for metastasis. Mutations in SF3B1 in purple occur in about 20% of tumors, and they are associated with a more intermediate risk of metastasis. And then mutations in BAP1, shown in red, occur in more tumors in 40 to 45% of tumors, and they seem to be associated with a higher risk of metastasis. Now, this is just a summary of the genes that we're looking at with our 7-gene panel. Again, as I mentioned, mutations in the 4 genes on the left-hand side frequently occur in tumors. I think 90% or more of all tumors will contain a mutation in one of these 4 genes on the left. And although they're not prognostic, they may help to confirm that the lesion was in fact sampled. And mutations in the 3 genes on the right are associated with differential metastatic risk. Importantly, there's a lot of research underway to investigate the role of these gene mutations as therapeutic targets, and so they're beginning to be included as entry criteria in some clinical trials. And I wanted to give a quick overview of some ordering logistics here. All 3 of the tests that I talked about can be performed from either a single fine needle aspirate biopsy sample or from formalin-fixed paraffin-embedded tissue. And there are different kind of ordering instructions for sample handling for each of those sample types. But for the FNA tissue, the sample is collected in a buffer that is supplied by Castle and then has to be frozen right away and then maintained frozen until it's shipped. For the FFPE tissue, we can accept either sections that have already been sectioned and mounted onto slides, or we can accept whole tissue blocks and we can perform the sectioning in-house and then return the tissue blocks once testing has been completed. So in the United States, these tests are very widely covered by patient insurance, but unfortunately that is not the case abroad. So here I have provided our international list prices. All of the orders for each of these tests requires a completed requisition form, as well as a completed credit card authorization form. And at this time, we do not offer our sequencing panel, the DecisionDx-UM-Seq panel, as a standalone test, but it can be ordered on its own for testing of metastatic tissue. So I'd be happy to discuss that if anyone is interested in learning more. We also have a few resources that we're happy to share with you if you're interested. We have a patient guide, which is a brochure that for patients that explains the testing process. And we've got an English and Spanish version of this brochure, but efforts are underway for additional translations. So we've got a Portuguese translation coming soon, thanks to Dr. Morales. And then we can also share links to videos that detail the sample collection procedure, if that is of interest, and it details, how to preserve the sample for testing. And with that, I would like to thank you so much for your attention. I hope this provided a useful overview of our test offerings, but I'm happy to answer any questions. So my contact information is here. You can reach out to me or to my colleague, Jennifer Cotter. And we look forward to hopefully serving you and your patients in the future.
Thank you very much. May I introduce our next speaker, Dr. ASAD JAVED. He's a clinical assistant professor of oncology at the Holden Comprehensive Cancer Center. He completed his fellowship training at Thomas Jefferson University, Philadelphia, and Mayo Clinic, Rochester. He's focusing on management of metastatic uveal melanoma and management of hepatic metastatic disease. Dr. JAVED is gonna talk to us about the management of metastatic uveal melanoma in 2022.
Thank you very much. Let me share my screen. Can you guys see it?
We can.
Good, good. So good evening, everyone, and thank you very much for having me. I am going to take the discussion into the next step, which is what I see in the medical oncology clinic. I'm going to get straight into it. That about 50% of the patients that we see with primary uveal melanoma, they do end up developing metastatic disease. And this is macrometastatic disease that we see on imaging, meaning clinically detectable metastasis. The liver is the most common site of metastasis in uveal melanoma. Approximately 90% of the patients, when they develop metastasis, they will occur in the liver. And oftentimes the liver is actually the first site where we detect metastasis. So as a medical oncologist, for me, the liver is the key. For me, control of disease in the liver equals patient survival. So we're from the medical oncology side, we are always closely and very cautiously monitoring the liver as to what happens in it after my colleagues in ophthalmology have seen the patient and done with the primary treatment. Patients come into our clinic with sometimes with a bit of a different perspective about melanoma, about eye melanoma, because they've read about cutaneous melanoma. And unfortunately, it's a different disease. It's a different species altogether, genetically speaking, and mutational profile and mutational burden wise. So the success story that we have seen in cutaneous melanoma is not quite there yet in uveal melanoma. But continuing on whatever has been discussed by our speakers so far, in the medical oncology clinic, why do I care about prognostication? Like, why does it matter to me? And as it was pointed out by Dr. ALSINA, this snapshot is from the NCCN guidelines that we follow in our clinic. Because when I see a patient who has had the primary treatment done, the question for me is, how do I monitor these patients? What kind of surveillance am I going to do? And my main concern is with the bottom three figures. In terms of what am I going to tell the patient, and how frequently am I going to monitor them for metastasis risk, and also what is the modality that I'm going to choose. So broadly speaking, uveal melanoma, and we've alluded to this in the discussion already, that it's split into low risk, intermediate risk, and high risk. I've highlighted the gene expression profiling. So we do incorporate that, at least I do in the clinical practice. So if a patient has had an FNA biopsy done and I have that information available, I do put it to use. So it's not a must-have, but it's definitely a good add-on piece of information to have. Having said that, if we don't have the GEP information, there are other parameters that we look at as well, and mainly it's whatever the ocular oncologist has measured in terms of tumor size and characteristics in their evaluation. So if a patient has low-risk disease, surveillance is typically, that's the least intensive form of surveillance that we do, that we image them every 12 months. If it is an intermediate risk disease, as it was referred to in the prior presentation, we continue surveillance for a total of about 10 years, and then we do imaging every 6 to 12 months. But when it's high risk disease, when a patient has, let's just say, class 2 disease, PRAME positive, BAP1 mutated, and high-risk features on the tumor itself, then the surveillance is the most intensive, where we do imaging every 3 to 4 months for the first 5 years, and then ease off of it a bit in the next 5 years, and then after that as clinically indicated. And the risk of metastasis is the highest in the first 2 years in a high-risk patient, after which it slowly continues to go down. But the first 2 to 3 years is when we have to really, really watch them closely. So some of the considerations in surveillance in the clinic, patient education is very important. Uveal melanoma is not like other types of tumors where 5-year surveillance is enough. And after that, you can really, the patient can go back to their primary care physician and they're essentially cured. We know that metastasis in this disease can happen several years down the line, sometimes even decades down the line. So there is a component of long-term surveillance with these patients. When we're ordering CT scans or PET scans or X-rays, we have to be mindful about exposing the patients to ionizing radiation, and the same goes for nephrotoxic contrast, especially in the elderly patient population as well. When we include modalities like ultrasound, we have to be mindful about limitations of ultrasound, such as the patient body habitus, operator dependence, the location where it's done. So there's a lot of considerations that we have to take place. We have to take into account when ordering these surveillance scans for our patients. But why is surveillance for metastatic disease important? So that highlights the question, why do all of this? Why continue with surveillance? And why is profiling of the tumor so important? Number one, there is enhanced patient emotional well-being. The patient knows that they have had their primary eye tumor taken care of, either enucleation or brachytherapy, and now they're being watched for surveillance and scans are negative. I had a scan right now, I'm good for the next 6 to 12 months. So it adds to the patient well-being. The second is the potential to identify oligometastatic disease. In a subset of eye melanoma patients, they will have disease in the liver, which is either 1 or 2 spots that can be treated differently. We don't need to give them systemic therapy. We can treat them with surgery. We can treat them with radiation. So that's a more definitive treatment. So it does change your management as well. Decreased morbidity from advanced disease. It is always good to see patients who have a low disease burden when you catch metastasis. Unfortunately, during the COVID pandemic, I saw a lot of patients who skipped 1 of their surveillance scans or even 2 because clinics were closed and whatnot. And by the time I saw them, they were very sick from their disease, and when a patient comes to you with hepatomegaly, distended abdomen, they're jaundiced, there's not much that you can do. So surveillance is important because you want to catch the disease early as well. And then, of course, you want to, in uveal melanoma, when there's still an unmet need for treating these patients, eligibility for clinical trials is crucial. So when a patient is in good shape, when the disease burden is less, they are easily available and they're easily eligible for clinical trials. And now in 2022, we have an FDA-approved treatment for uveal melanoma patients. A subset of uveal melanoma patients can benefit from an FDA-approved treatment. And that's a form of immune therapy. I'll talk about that in a minute. But immune therapy works best when the disease burden is low. So the lower the disease burden, the better it has a chance of working. So I'd really, really like to catch this disease early so I can actually give them a treatment for which I anticipate that there would be reasonable efficacy. And what is the use of risk stratification now in primary uveal melanoma in the MEDON clinic? Counseling is important for the risk of recurrence. If there's a patient with a low risk disease, class 1A tumor, small tumor size, you can tell them that, we need to do scans every 12 months because your risk of metastasis is low, as opposed to somebody who has the highest risk of disease. You need to counsel that patient a little differently. You need to tell them, hey, you need to be on top of this. We need to do scans this many months, this many years, and this is something to watch more closely. And it changes it helps me with the choice of modality as well, right? So again, if somebody's got a small tumor, class 1A, PRAME negative, I'm not going to subject them to CT scans and MRIs every 3 months. It's probably going to be an ultrasound every 6 months or something less intensive. And so same goes for the frequency of the surveillance as well. And one of the things that helps me is that it adjusts my threshold to chase a lesion that I see. We all know that with imaging, there is a risk for false positives, right? Whether that's ultrasound, CT, or MRI. And if I see a lesion in a low-risk patient, and it's a difficult spot to biopsy, I have the luxury of saying, hey, wait it out. 3 months, 6 months, let's do another scan and let's find out then. Versus if it's a high-risk lesion, a high-risk patient, and we see an indeterminate lesion, my threshold will be a little different to chase that spot and to find out what it is. And then identifying a patient for adjuvant clinical trial. And Dr. ALSINA referred to this already. Our clinical trial portfolio in the adjuvant setting in the United States right now is not as robust as it is in the metastatic setting, but I do anticipate that in the near future, we'll have more and more of these trials. So it's important to identify these high-risk patients and then enroll them in these studies. And the systemic therapy landscape in uveal melanoma has been very disappointing up until 2021. We had no FDA-approved treatment option. And patients with, if you look at the literature, the past 10 years, you will keep coming across the statistic over and over again that the estimated 1-year overall survival is approximately 50% or even less, right? So chemo doesn't work. Targeted therapy, so far, no major success there. And checkpoint inhibitors, which have revolutionized the treatment in cutaneous melanoma and many other tumor types, that has not unfortunately translated into uveal melanoma realm, where responses are still less than 10%. So the latest in uveal melanoma, metastatic one, a huge relief for myself, for my patients, is tebentafusp. This is now it is FDA approved at this time. It was FDA approved about, I think, February of this year. It was approved, and it's an interesting molecule. So if you look at the top part, this is the tumor cell, and the bottom you have a T cell. And the drug, which is tebentafusp, acts as a magnet between the T cell and the tumor cell. So it enforces a handshake between the two agents. Something which is not already happening, because uveal melanoma is not as immunogenic as cutaneous melanoma is. So this drug really engages the tumor cell to the T cell and elicits an immunological response. The peptide here that is mentioned is a requirement that the tumor cell should be expressing a component of this peptide, and that the antigen is GP100. A peptide of GP100 needs to be expressed by the tumor cell, and for that we need a certain HLA profile of the patient. The patients who are eligible to receive tebentafusp need to be HLA-A or 2 or 01 positive. So that positivity is a requirement, and unfortunately, 50% of the Caucasian population is positive for HLA-O2/O1 allele, but 50% are not. So even when my patients are diagnosed with metastatic uveal melanoma, the big question is, hey, what is my HLA status? And we have to look for that, and then we have to tell the patient, hey, you're positive, you're a candidate for it, you're negative, you're not, and we have to consider you for clinical trials and other treatment options. So the tebentafusp was approved in a phase 3 trial. This was published in the New England Journal of Medicine last year. And 378 patients with metastatic uveal melanoma who were treatment naive, they were randomized to get Tebi or investigators' choice of drug, which could include pembrolizumab, ipilimumab, both immune checkpoint inhibitors, or dacarbazine, which is chemotherapy. The drug is given weekly. It was given in an escalating dose. And the primary endpoint was overall survival. And as you see on this slide, the yellow line is on the top, which is TEBI, and the blue line is the control group. And there's a clear benefit in terms of overall survival with use of tebentafusp. And this was the first time actually in 3 to 4 decades that a systemic therapy drug has actually shown overall survival improvement. So in the world of uveal melanoma, it's a big deal drug. And it creates a lot of hope for the future that, there will be other treatment options that will come to the scene as well. But the estimated 1-year overall survival with TEBI was 73%, control 59%, and the 6-month progression-free survival was 31% compared to 19% in the control group. And this was published last month in Nature Medicine, and this was actually a follow-up to the phase 2 data. So patients in the phase 2 setting who were previously treated with tebentafusp and they got and they had metastatic uveal melanoma, this is a bit of a glimpse into the longer term for survival. So if you look at the New England Journal paper, that had a 1-year overall survival, but now we have some data reflecting on a 2-year follow-up. So in this study, the 1-year overall survival rate was 62%, and 2-year overall survival rate in these patients was 37%. Again, to be noted that these were previously treated patients with advanced disease. As a comparison, historical 1-year overall survival rate was 37%, and the median overall survival was also 7.8 months, which is less than the numbers at the top. What is my approach towards patients that I see in the clinic? Once the diagnosis is confirmed, there's a few considerations. What is their performance status? What is the disease burden in the liver? It's very important because if it's oligometastatic disease, maybe I would approach it differently. And then what is the burden of disease? Even 90% of the time, a lot of disease will be in the liver, but sometimes you will see disease which is not so much in the liver, but you have extrahepatic sites of disease. When all of that is taken into consideration, check them for HLA status. If they're positive for O201, they're candidates for TEBI. But if they're negative, then there's a whole plethora of other treatment options that we have. And it's not in the scope of this presentation that I can go into the details of all of them. But the bottom line is that we do have a lot to offer our patients. Clinical trials always preferred. We have a whole area of liver-directed therapies. Immune checkpoint inhibitors are, even though the response rate is low, they're still utilized. And there's, I think in the near future, we will have tebentafusp being combined with these immune checkpoint inhibitors. And then again, for oligometastatic disease, we can consider SBRT, we can consider surgery, we can consider ablation. And finally, I want to show, this is a bit of a landscape of what is going on in the field. So these are all clinical trials in metastatic uveal melanoma in the United States only. And probably these are 80% of the ones that I could put on one slide. But I've highlighted different categories. So there's checkpoint inhibitors always under consideration. There are different modalities of radiation therapy that are being investigated. A few trials have already been completed with liver-directed therapy, radioembolization, immune embolization in combination with checkpoint inhibitors. And lots going on in the realm of molecular targeted therapies. Sometimes in combination with checkpoint inhibitors, sometimes in combination with different agents. And finally, cellular and adoptive therapy, which is a very, it's something that I'm personally very interested in, is also being explored because it's been utilized in many other different tumor types, especially cutaneous melanoma. And now that is coming into the uveal melanoma realm as well. So even though a patient, if they test negative for HLA-A2 or O201, it is definitely not the end of the world. There's a lot that's to be offered. And 2022 really has been a huge year as far as things on the metastatic site are concerned. And I think the more medical oncology and ocular oncology comes together, there's a lot we can learn from each other, and I think there's a lot to improve on and lots to do. So thank you very much. Thank you for your time.
Oh, fantastic talk. Really high level overview of managing metastatic melanoma. So we very much appreciate it. And thanks to all the speakers tonight for such fantastic talks. So we're going to go through some of the questions here. And there are a couple of technique questions, but one of the ones that I wanted to get to, we saw a question asking about T3 tumors that are also class 1A and understanding their risk of metastasis. So I'll direct this to Dr. Singh if you don't mind. If you have kind of a large tumor that's a class 1A, or perhaps by contrast, even a small tumor that's class 2, kind of how do you think about that in your management process?
So ocular management is no different. So we're talking, I guess, about systemic surveillance. How would you counsel such patients? So, Kath, I really enjoyed your presentation. It was very nice and backed by all the data that they have. But we also know that in clinical observations, and not just limited to us, other people, that some of the small tumors tend to do better, even if they're class 2. So the class 2, and we say they're going to die 70% at 3 years or 5 years. And that's not what's happening. So somewhere along the line, for whatever reason, small tumors, when they're class 1, of course, they do very well. When they're class 2, they do better than what's predicted. And so I tell the patients, we'll do the study and the report comes, and obviously we're obligated to tell them the published and accepted numbers. But I tell them that this isn't as bad as it might appear. Chances are you're better. But we don't have data to say how much better you are. But you're better than what they're saying. And I leave it at that. But and again, in some of the trials, some of these adjuvant therapy trials, they are considering tumor size also for enrollment. If it's a small tumor with class 2, that's not good enough because they realize. But more important than all of it is when we have these trials, adjuvant trials, that do not have a control arm. And you say, oh, your prediction is of metastasis is 70%, and in my study, survival is 40%, 80% or 90% or whatever. Then that's not just because your treatment is effective, it's that the prediction may be overly pessimistic. So it's telling us that we should always have a control arm to really get into adjuvant therapy that's widely acceptable. To come to that level, we have to have a control arm because we never can rely on a synthetic control. This will be a synthetic control. You say, well, this is what is expected and I'm better than that. But what's expected may be wrong. That's kind of, I think we are headed that way. Okay, next paper we will write will be on synthetic control. Okay, pitfalls.
Other speakers, any comments?
I have a question for Dr. Javed. Dr. Javed, are you able to hear us? Are you still here?
Yes, I am.
Yeah.
Yes.
I have to say, very nice presentation, and we always like to hear people who are outside our specialties. So I really like to hear other people that are smarter. And we all do surveillance. I've been doing it for years. Is there any data to say that surveillance actually makes a difference? I agree with everything that you said, and we do it, and I will not stop it tomorrow. But I don't think there is any scientific data in behind any of it to say that surveillance actually makes a difference. Just
I agree, and I've actually come across some of your work and some of your presentations in the past too, and you allude to that very correctly, that it doesn't make a difference because survival in these patients, they tend to live the same no matter what you do. And the whole talk about lead time bias and everything, right? But I think in right now this year, especially now that we have drugs which can improve survival, maybe 5 years down the line, this answer will be different. Right now, no, I cannot give you data, or I cannot tell you proof that, hey, this is surveillance will actually make a big difference.
So I think we should all pay attention. We should all try and get some kind of data, some kind of study, something to kind of support this, what we do. We do this all the time, and yet we never bother to collect this information to give it a scientific basis. So I think this is a question you have to answer. So it makes all sense. Patient wants it, we want it, but somehow we haven't been able to add up these numbers. So I think this is something to think about. All the young people in the crowd, pay attention, okay? Do something. Okay. Hatim, you are included in that. Hatim, Krima, you are included in the young people.
Not young person anymore. I have a question here from Argentina. Argentina is playing well. Let's see what they will do. So it's from Dr. Arturo to Dr. Binkley. Why use sutures after biopsy if we do not use them in vitrectomy?
Yeah, so that question was for Dr. Binkley, and I think she had to run back to clinic, but she did send a quick message that says that she does often use sutures for her vitrectomies regularly, but especially in the situation of tumors, she's concerned about the risk of extraocular extension, and with changing pressures and the possibility of egress from the site of the sclerotomies, she felt like suturing the sclerotomies made the most sense in that scenario.
Okay.
Another technique question. When approaching biopsies, and Dr. Krama, I'd love to hear your opinion on this as well. When you're doing transscleral biopsies for ciliary body tumors or for anterior lesions, what is your approach to try and reduce extraocular extension? Are you cryoing those, or if you're putting a plaque directly afterwards, do you not do anything?
Actually, I have a little presentation. If you don't mind sharing it with you, it would just take 1 minute. Can I share my screen in a way?
Yes.
How can I share my screen from here? Yeah. Can you see that, guys?
Absolutely. Yep.
Okay, so basically these are the techniques I use, depends on where is the tumor. So I do also chandelier for posterior shallow tumors, but I can do it indirect if the tumor is so posterior, and I can approach it with indirect. Obviously, things are inverted and it's confusing, but you can train yourself on it. Like you stand diametrically opposite to where the tumor is, you insert your needle to the center of the vitreous, and then direct it down to engage to the apex of the tumor. Open biopsy in case if I'm doing resection, but we don't do that, translimbal. But the most two commons are transscleral biopsy and 18 gauge needle biopsy after inoculation. So here is what I do. I have 10 milliliter syringe, eagle tubing. The needles I use is usually 27 if I'm going transscleral, and transvitreal I use 27, but a long needle that can go all through the eye. I don't do a trap door like ARUN did. We do DNA-based MLPA, so we have to take a buccomucosal swab. We expose the area where the tumor is. We put our marks and stuff. And then I use the 27 gauge needle. So what I do is that I make a mark at half tumor thickness as we see it in the ultrasound. And I add extra 1 millimeter for the scleral thickness. So this is the mark here. It's actually, sorry, it's about there. And then I put a mosquito forceps at that mark that I made, and I bend the needle. So that angulation creates a shoulder, so the needle cannot penetrate beyond that. So I know that the needle, no matter how I move it around, it doesn't go beyond half of the thickness of the tumor. It's not so close to the retina that with suction I can injure the retina. And I know that the suction power is on the upper half of the tumor, where more mutation happens than at the base. And then I enter the sclera where I mark at the epicenter of the tumor, and I do a couple of digs and drills to dislodge cells. And then I ask my assistant to give full negative aspiration to 10 milliliter, which is the syringe I have, and to count at that negative pressure for like 15 seconds, and then release slowly. And by doing that once or twice, you start to see with the naked eye that the biopsy material is accumulating in this area. And then what I do is that, as you see, I'm putting a sponge, a micro sponge here, or a Q-tip, just in case if some blood leaks outside, it's taken away by the Q-tip. Before I come out with the needle, and by the way, like after I do the aspiration, I release completely, so there is no negative pressure. Then I ask my assistant to plug the hole with this Q-tip. In the meantime, I bring my plug and just put it while my assistant is withdrawing the Q-tip from over the hole. So with that technique, I do not get any extrascleral problems. I've done maybe over 600 biopsies, none of them leaked outside. And also the advantage, like I make the case here for transscleral. Transscleral, you can get more than one core, 2 or 3 cores to avoid tumor heterogeneity. You can enter down to tumors of 3 millimeters. The bevel itself is 1.7 and 27 gauge needles, so we can bend at the bevel end, and you can enter perpendicular to that. Another trick I do is that when I cut the muscle, I leave a small stump of 1 millimeter, and I hold that stump with the forceps, and that helps me to rotate the eye more than usual. So like if I pull just from the brittle sutures, it doesn't rotate the eye as much. But if I hold from here, I can go a little bit further beyond the equator, so I can gain access through transscleral to more tumors, and I don't need to perforate the retina. No worries from intraretinal hemorrhage. These eyes, after we take the biopsy, we look inside as if we did not touch the tumor. So I try to do it transscleral as much as I can. Thank you.
Excellent. So thanks for sharing that technique. I think we got an extra bonus there. I would also like to say that in our chat, Dr. Mayra has put the information for the video links that KATHERINA was mentioning. So we have those links as well. And then to Dr. Singh and Dr. Krema, I'll make a petition on behalf of the Pan American Ocular Oncology Society. I know you have some wonderful videos for your biopsy techniques. If you have any interest in sharing those videos with us, we would love to have some of those on our website to provide a little bit more information. So thank you to all of our speakers for such a fantastic job, a fantastic webinar. And as always, we enjoy learning from you.
Thank you.
Thank you, guys.
That's what I was going to say as well. I always learn so much hearing you. Thank you very much.
So I am putting together the videos. The videos are edited, and that's not a problem. I'm trying to find a sophisticated way of merging with the slides, and I'm looking for a high quality graphic designer. I haven't found any. So I wanted, because once the video goes online, it's going to be there for hopefully some years. So I wanted really high quality. So I'm working on it, and you'll have them. Okay. So give me some time. Okay. All right. Good to talk to everyone. Thanks so much. Very nice, educational. Yeah.
And then one last thing I wanted to say, Dr. Molina, thank you so much for being a fantastic president for this year. Thank you for guiding us throughout this process. You're amazing.
You are amazing. The whole team is so amazing. And well, one more amazing year with you. I think it's 3 years we are together. So thank you very much. So great working with you, and so great that we can count of all of our friends here teaching us. Every single webinar is amazing listening to you. So thank you all, and once again, and all the friends that are here, and have a great night. See you next year then.
Thank you. Bye-bye.
Bye-bye.